to present along with Amanda tonight. I think we bring a good background between, I work in a COPD outreach program at the Ottawa Hospital, safely transitioning patients home, doing home visits, as well as telehome monitoring and some background in pulmonary rehab. So I'm anxious to present with Amanda, and I've learned a lot as far as the palliative care component. So with the chat box, we hope it's kind of interactive. We'll try to address questions as we go through, just so everybody gets kind of the most value out of the presentation possible. So again, we're going to present on tools and resources for palliative care and how to apply that to a COPD population. So just for full disclosure, there is no really financial disclosure or potential conflicts of interest for neither Amanda or myself. And objectives for tonight's presentation. So to understand the pathophysiology of COPD and how it contributes to symptom burden, to understand the pathophysiology of dyspnea as it relates to COPD, to identify some diagnostic criteria and assessment tools to monitor disease progression, and to identify which patients would best benefit from a palliative care approach, and explore some management tools that could be adapted in the palliative context, as well as we'll discuss some pharmacological and non-pharmacological approaches. So we know COPD is an umbrella term for both chronic bronchitis and emphysema. 80 to 90% of cases are caused by smoking. So smoking is the #1 modifiable risk factor for this disease. There are other causes, however, so genetic reasons like an alpha-1 antitrypsin deficiency, most notably seen in kind of the younger patient population, and then occupational dust and chemicals, secondhand smoke, frequent lung infections as a child, and then wood smoke and other biomass fuel used for cooking. Again, the umbrella term, so emphysema, we know it mostly affects the alveoli, air becomes trapped, enlarged, and really impairs the diffusion capacity across those membranes. And then in chronic bronchitis, you have the inflamed, larger airways with tightened, smooth muscles, the narrowing caused by inflammation, and then a large portion of this patient population also has a lot of mucus production. So our first poll question. I think Carl is going to put this on the screen. So what are the most common symptoms of COPD? Cough, sputum, shortness of breath, wheeze, frequent colds, or all of the above?
Yeah, it should be launched there for people. I'll just wait as the answers come in here. Oops, I think there was just an error there. I've relaunched it. Okay, it seems like it worked this time. It seems like the voting's working for most people, but if it's not, just write your answer in the chat there. It looks like we have most people answered. I'll just give it 2 more seconds here. All right, there we are. There should be the results.
So the majority of people voted all of the above, and that's right. All of those symptoms are the most common symptoms in COPD. Thanks, Carl. So this is a good kind of a stepwise approach by the Canadian Thoracic Society to demonstrate, how to manage COPD population. So essential to managing a COPD patient is early diagnosis. The gold standard for diagnosing a patient with COPD is either spirometry or pulmonary function tests. And then once the pulmonary function test confirms the diagnosis, then it's a good idea to start using some tools to monitor disease trajectory, to monitor symptoms, symptom burden, and kind of lung function. So there are a few tools that we use. I'll explain a little bit more detail further on. So there's, for dyspnea scale, there's the Modified Medical Research Council scale, the COPD assessment tool, and then of course the breathing test to monitor lung function impairment. And you can see early on, essentially at diagnosis, there should be education, smoking cessation, vaccinations, and then you can just see how therapies are prescribed kind of further on into the diagnosis, as well as treatment plans. Here's some two great tools we use in pulmonary rehab, and we also use at the COPD Outreach program, essentially to monitor patients when we first assess them, and then monitor them. We usually do every 3 months in COPD Outreach. I'm sure it's longer term in pulmonary rehab. Again, the dyspnea scale they use between 0 and 4, 4 is being most compromised or most impaired. And then the GOLD criteria, GOLD 1 to 4, with very severe being less than 30%. And those are a large portion of the patients that do go to pulmonary rehab or in the COPD Outreach program. So you can see how we would like to reach out to the palliative care people as much as possible to help us manage symptoms for that patient population. Again, this is the CAT score. It's an easy tool that can be administered in the doctor's office, at primary care office, respirology office. And essentially, it scores kind of the symptom burden for patients. The higher the score, the more symptom burden. So this is a good tool to really monitor the trajectory of their illness. Just some, probably a review for most for the pharmacological management of COPD. So we know that pharmacotherapy for COPD reduces symptoms, reduces frequency and severity of COPD exacerbations, improves exercise tolerance, and improves health status. This is from the Canadian Thoracic Society. Again, kind of a stepwise approach on how to manage the milder COPD. Would just have essentially one puffer, either short-acting or long-acting bronchodilator. And then as disease progresses and they become more symptomatic, either infrequent or frequent exacerbations, you can see how more medication is introduced. If they have frequent severe exacerbations, they're always in and out of the hospital, CAT score over 10 or MRC, you know, this is the old MRC scale, but the modified between 2 and 4, you might want to refer to a respirologist for other treatment. And then, of course, in the newer guidelines is the recognition of the asthma COPD overlap syndrome. And in this patient population, you'll always see an inhaled corticosteroid prescribed, but not necessarily in the COPD patient. You may not necessarily see the inhaled steroid. This is a great chart from ResPrec through the Lung Association that shows essentially all the different classifications of bronchodilators available to patients, as well as a whole slew of delivery devices. Often when I go to the patient's home after discharge from the hospital, we want to review their medications, their inhaler technique. We're given a Ziploc bag full of medications that they likely been prescribed in the community, as well as medications that may be on formulary at the hospital. And really, they don't really know which medications to choose. So we choose what the best delivery device is for the patient and what the right classification of medications is.
Wendy, there's a question in the chat regarding asthma from Sherbrooke. I'm just going to read it out. It goes, how does asthma relate to COPD? Do people tend to have both?
So kind of twofold question there. So somebody with uncontrolled asthma throughout kind of their either childhood or adulthood actually can develop COPD through airway remodeling. That's why controlling the asthma population is essential. And then how is it related to COPD? Yes, you can have both. If you have somebody that's, especially if somebody has allergies, which is often, you know, it's obvious as far as allergies, but their blood work, high eosinophils in their blood work, they can have COPD with asthma. Those patients tend to cough more. They respond, but they require a steroid. Absolutely, that's the first line therapy for an asthmatic patient. So definitely you can see both, or you can see an asthmatic patient turn into a COPD patient through airway remodeling? That answered that question. So this is a device that my colleague and I have used assessing patients in hospital or in home. It's important to ensure the patient is using the right delivery device. A lot of these patients have very poor inspiratory effort, shallow breathing, they may be older, frail. So this device, we're not using it since COVID, but it has a disposable filter that you can use, so it can be used for multiple patients with a disposable filter. And essentially you get a patient to take a deep breath using the device, and depending where on the scale kind of the needle lands will determine what puffers best for the patient based on their inspiratory effort. So if you look at kind of the diagram in the bottom left-hand corner in the purple, say around 5 o'clock, you see HandiHaler. HandiHaler is Spiriva, an anticholinergic, long-acting, that's often one of the first medications prescribed for COPD patients, but it also requires a pretty significant inspiratory effort to use that device. So as the patient becomes more frail or poor inspiratory effort, we tend to go around the circle. And if you look at the bottom left-hand corner, you see the MDI, which is like Ventolin, Atrovent, and Zenhale. Use that with an aero chamber that requires the least amount of inspiratory effort, and pretty much almost equal to that is the Respimat delivery device, which is a mist delivery device, which is actually the only one that's not breath actuated. As you start taking an inhalation, you press the button and you inhale the medication at the same time as your breath. You don't need a huge inspiratory effort to get the medication. So often patients are switched to that mist delivery device if they do have poor inspiratory effort. For patients, you know, they're for whatever reason, they're having a hard time either remembering to take their puffers multiple times a day, or they have multiple puffers and really want one puffer. If they are on triple therapy, so they're on an inhaled corticosteroid and then the 2 long-acting bronchodilators, you may wish to switch them to a medication called Trelegy Ellipta. And it doesn't require a huge inspiratory effort, so it is a good choice. And that is one inhalation that lasts 24 hours. So it is a good option for some patients. And of course, every opportunity you can, please review inhaler technique with your patients. We know the literature says that with proper inhaler use, patients will have less COPD exacerbations. And you can see, and we always recommend an aero chamber spacer with the multi-dose inhaler, and you can see why. By using the aero chamber, you can see the majority of the medication actually gets deep into the lungs as opposed to the back of the throat. And a lot of patients will complain of hoarse throat, sore throat. So, you know, when I talk to patients, it's these medications do cost money. And you want to get, the best bang for the buck, so to speak, as far as getting the best delivery of medication. Sometimes patients will ask, which inhalers do I use first? So the literature says, in general, use your short-acting inhaler first if they're taking Ventolin or Atrovent. This will open up the airways and allow your next inhaled medication to get into the lungs. Then use the long-acting inhalers next, and then finish off with the steroid inhaler, because the patient will need to rinse their mouth to avoid thrush. And when I did work on the inpatient units at the rehab center, we did have patients complain of a sore throat. So when I do provide this education to nurses, I always ask them to grab a flashlight and look in their mouths to see if there's any white spots. And if there are, to certainly report that, because the patient will likely need nystatin. And that's happened more often than not.
And then another question here, Wendy.
Sure.
Is COPD the same as emphysema?
So COPD is an umbrella term for 2 obstructive lung disease, which are either emphysema or chronic bronchitis. So if somebody says, I have emphysema, if confirmed by pulmonary function test, then they have COPD. Good questions. So for puffers, for an MDI, Atrovent or Ventolin, or another example would be Zenhale, patients, they need to wait 30 to 60 seconds between puffs. If you're using a meter dose inhaler, it does take that length of time for the canister in the device to repressurize before the next dose. And the literature says our patients don't do this, and we're not going to really expect them to do this, but ideally they should wait 5 minutes when switching to a different inhaler. And some of our patients realistically are on, if they're on Ventolin plus 300 inhalers, that's 4 inhalers. They're not going to be taking their puffers for 20, 30 minutes. We know that in the real world. For puffers, so most medications are inhaled because they act directly in the lungs. They work faster than orally administered medications. They cause fewer side effects than orally administered medications. So you can see the benefit of the puffer for sure. Just very briefly, I know the topic is on COPD. Pulmonary fibrosis or interstitial lung disease is not COPD. It's not an obstructive defect. It is scarring of the tissues of the lungs. So the alveoli, they're scarred. There's not great gas exchange across the alveoli, and you don't really have that good pliability of the lungs. They're scarred, they're stiff. This patient population, when we go to admit to pulmonary rehab, if there's 2 people on the waiting list, a COPD or pulmonary fibrosis patient, we may admit the pulmonary fibrosis patient first, of course, depending on history, because this patient population tends to deteriorate more quickly. So just some pharmacological management of pulmonary fibrosis, just very briefly. So I think Carl's up with his next question. So do inhalers work for patients with interstitial lung disease, like pulmonary fibrosis, without underlying obstructive lung disease, like COPD? So if a patient doesn't have COPD and only has pulmonary function test, would a puffer work for that patient?
And Wendy, just while people are taking their time to vote here, I just want to let you know there's another question in the chat, maybe before we move on after we answer this question.
Okay, great, thanks.
Okay, it looks like most people have answered, but I'll just give it a few more moments here. It looks like it's working okay for people this time with the poll.
Great.
All right, I'll share the results here. Looks like we have 39% of people said yes, and 61% said no.
Okay, great. So this, it is confusing, and I know when I also deliver again education to the nurses on the pulmonary rehab unit, they expect that everybody that's admitted to pulmonary rehab should be on puffers. But interestingly enough, patients with pulmonary fibrosis, because it's not an obstructive lung disease, if they do not have underlying COPD, which some patients do, but if they do not have underlying COPD, puffers are not effective for this patient population. There are, however, 2 medications that are approved in Canada for pulmonary fibrosis, and those are Respiratory and OFEV. They're 2 oral medications that both have anti-fibrotic and anti-inflammatory properties, and they slow the disease progression. Interestingly enough, so these 2 drugs do have a lot of side effects, mostly GI side effects. There's actually a nurse in the community that's assigned to these patients to really coach them through how to manage those side effects so they continue with the medication, because it is so essential to that slowing the disease progression. Was there another question, Amanda?
Yeah. So I think it's LTC, so long-term care, I presume, had a follow-up question to the question about COPD and emphysema. They said, are people with COPD more likely to get dementia?
Oh.
Just wondering, based on what they've seen with their residents.
That's a good question. I don't know the answer to that. But I guess with chronic, if they did have chronic low oxygen levels, perhaps. I don't know the answer to that, honestly. It's a good question, though.
Maybe Wendy can ask some of her respirology colleagues and we can get back to you.
Yes, I don't know if Carl can take questions and I can get back to individuals.
Yeah, absolutely.
Thank you.
I just wanted to add to go back to your discussion about those medications that reduce the scarring in patients with pulmonary fibrosis. It's also something, I don't specifically talk about this in the palliative care section, but it's something that we can have conversations with patients about whether they want to consider stopping this medication, particularly if they really have been struggling with the GI upset and GI issues of being on this medication. If we're meeting them and they're very close to the end of their life, you know, it's certainly something that I have conversations about deprescribing because it can improve quality of life to no longer have the same GI side effects from these medications.
Yeah, that's a great point, because a lot of these patients are definitely further along in that trajectory of illness, and now the benefits are likely now not outweighing the risks. So yeah, that's a good point to deprescribe with all of those side effects kind of more towards end of life.
And Colby Burns actually found some answers for us about the COPD and dementia question. So he writes, the association between COPD and dementia is still observed even after adjusting for other vascular diseases, suggesting COPD is an independent predictor of dementia. And it sounds like he cited an article in here called Increased Risk of Dementia in Patients with COPD. Interesting.
Yeah,
Thank you,
excellent.
Colby.
Thank you, Colby. So we talked about the pharmacological management of both pulmonary fibrosis and COPD, and we'll just discuss some non-pharmacological management of chronic lung disease. GOLD guidelines looks at, kind of breaks it down into different groups. So we talked about GOLD A, B, C, D. For GOLD A, absolutely essential is smoking cessation, counseling, and treatment. Recommended is physical activity, and then of course the guidelines suggest all their vaccines. And then for patients with an FEV1 less than 49%, again, everybody smoking cessation counseling, recommended physical activity, vaccines. And then this is where pulmonary rehab is recommended. And when I talk about pulmonary rehab, exercise alone or education alone is not does not show improvement benefits for pulmonary rehab. It's exercise and education together will show the best outcomes for pulmonary rehab. Smoking cessation, we briefly spoke about that. So interestingly, you know, we have many of our patients, you know, I've smoked for 50 years, I'm not going to quit now, what's the point? So we do have many people believe that once smoking damage has been done, smoking cessation isn't necessary anymore. This graph, however, clearly demonstrates the importance to quitting smoking, even if serious damage is already present. So if we look at the blue line, it shows somebody who continues to smoke. They have pretty significant lung function decline if they continue to smoke. The red kind of corrugated line demonstrates, represents somebody who hasn't smoked. And then the lines in between demonstrate people who have quit. So I always tell patients, you know, the lungs you have are the lungs you have. They're not necessarily going to get better, but by quitting smoking, you can certainly slow the rate of decline. So I think, you know, this is an important graph to show to people if they're considering quitting smoking, or even those that aren't. Again, just kind of flipping back to pulmonary rehab. We talked about an exercise is an essential component, but then the education as well. So in pulmonary rehab, reviewing an action plan, breathing techniques, oxygen, spirometry, managing stress and anxiety, energy conservation is huge in this patient population. Nutrition, lifestyle, impact on family. I review the medications. On an individual basis, more so, we talk about strategies to improve sexual activity. And then what we're not doing well, admittedly, is introduction to advanced care planning and palliative care. And that's something that we need to improve on. For the COPD outreach program, again, we assess patients in hospital, follow them to home, and then do a home visit and provide a lot of education, including inhaler techniques. And we review an action plan. The action plan essentially guides the patient to recognize signs of a flare-up and coaches it along to get early treatment by their primary care provider. So it's important for this patient population to know, on a green day, it's a day that they're doing well. They may still produce sputum, but what is the color of that sputum? What are things that make them short of breath? If they tell me walking upstairs makes me short of breath, but sitting down doesn't, and 2 days later, sitting down makes that person short of breath, that's a flag. And then what do they do on those days? They use their puffers as prescribed. And then we talk about what are the symptoms or the signs of an exacerbation, increased shortness of breath, cough, and change in sputum color and quantity. If after 2 days, patients have symptoms of an exacerbation, we encourage them to use their prescription for prednisone with or without antibiotics. If they don't have a prescription on hold at the pharmacy, or at home, we encourage them to reach out to their primary care provider or respirologist early to get a prescription to manage that exacerbation to avoid hospitalization. In addition to that, we encourage them to increase their Ventolin, use their relaxation breathing techniques, and they may or may not be increasing oxygen. Oxygen, typically we want them to be between 88 to 92%. If for some reason they couldn't get a prescription or they deteriorated quickly, because some do deteriorate quickly, we of course advise them to present to the emerge, and their symptoms are typically extreme shortness of breath, confusion, drowsy, and chest pain. A similar type of action plan that we've developed at the rehab center has one more step in it. There's a blue day instead of a red day, but it breaks down very similar to the Canadian Thoracic Society guidelines. But it just breaks down further into some kind of strategies to do within each day. So a green day, take medications as prescribed, prioritize activities, do lung clearance. And then the yellow days, you want them to continue to move, use their rescue medication maybe more often, do their lung clearance, increase their fluid intake. And then red day, alert somebody that you're not feeling well, seek medical advice, adequate fluid intake, and then the way it was developed at the rehab center is blue days need to get to hospital. So often, despite everybody's best efforts, and patients have been managed and optimized as far as bronchodilators, exercise training, they've been prescribed and are using supplemental oxygen. They've done all the non-pharmacological strategies, including pulmonary rehab, pursed lip breathing, using a fan, relaxation techniques, pace breathing. Some patients still, despite all of those efforts, continue to have refractory dyspnea, continue to have that shortness of breath that just will not go away. So this is often when we reach out to our palliative care colleagues to help us with symptom management for this patient population.
Wendy, before you go to the poll question, there's a question in the chat. So there's two questions. One question from Allison I'm going to bring up at the end, but the question from Sherbrooke is, do you have any advice on how to recommend physical exercise to patients with COPD? I find this is sometimes a difficult conversation to have with residents/patients.
It is. We always say, the more you use your muscles, the better your lungs will be. And a lot of them are afraid. They don't know what their limitations are. So just very gradual. Well, if somebody lives in an apartment building, at first, if you have a support person, get up and walk one length of the hall with somebody, and that's it for that day. It's just a very, very slow integration of some kind of exercise routine into their life. And, the better shape our muscles are in, the better shape our lungs are in. And I think it's more they're fearful. They need to know their limitations. So, shortness of breath is not a bad thing. If you're short of breath, it's not an excuse to go and increase your oxygen. What shortness of breath means is stop what you're doing, sit down, do your deep breathing exercises, and kind of control your breathing. So, encourage patients, that they take their puffers 30 minutes before they exercise, so their lungs are fully dilated. Having a support person there on a green day is the day that you're going to want to maybe exercise. If you're having a yellow day or bad day, that's not the day to start it. So I think just, encouraging them, supporting them, letting them know. And it's okay if you have if you have a walker, if you have to sit on your walker 5 or 10 times down that hallway, that's okay, as long as they're moving.
And sorry, one more question from Pam. Is positioning onto your stomach a strategy as it is with COVID?
Yeah, prone. I haven't seen that evidence in the COPD population, no.
I mean, I can kind of speak to that a bit, Pam, from my ICU background. Proning a patient or putting them on their stomach is fairly effective in managing ARDS, acute respiratory distress syndrome, which is why you see these patients with COVID who are in such significant respiratory distress in the ICU are being put on their stomach, and it works well. But I don't think there's evidence to support it for COPD.
These are tough questions.
They're very good questions.
That's great. So the next poll question. So this is an interesting question. Do patients with chronic lung disease feel recurrent exacerbation or flare-ups impact their overall lung function? So if they, if they have exacerbations, do they think that they just bounce back and get back to their baseline? It's actually very interesting what they, how they perceive their disease.
Okay, I'll just give it a few more moments here.
And we'll talk about, how patients perceive their disease, the trajectory versus what's kind of known as from a healthcare perspective.
All right.
Patients with chronic disease exacerbate or flare-ups.
So it looks like we have 42 people, or 88% of people, saying yes, and we have 6 people, or 13% of people, saying no.
Yeah, it's interesting. So I'll go to the next slide to show you the answer to that. So it's interesting. So this is a patient experience and expectation as far as their trajectory of illness. So in the dark black line, we can see on the left-hand side, the patient's sick, they're not doing well, then they get better. They're sick again. If you look at this graph, it almost looks like the patient perceives that they go back to their baseline function after every exacerbation, and then they just suddenly die. And this is a graph from Health Quality Ontario. But interesting, in this other article, and I think many of you are likely familiar with this graph, the expected disease trajectory, and this is kind of for chronic disease. With every exacerbation, there's progressive deterioration of lung function. So I'd like to show patients this graph. When I show them the action plan, just to demonstrate how important it is to really treat those flare-ups and get early treatment. You don't want to end up in the hospital often with these exacerbations. I always say, every time you go to the hospital, it takes a bit of a piece of your lung with you. So it's really important to manage those flare-ups early.
And Wendy, a question in the chat. Is there a correlation between dyspnea and depression? Should we routinely be screening for that?
We do screen, is it the COPD that's causing depression, impact on quality of life? We do screen for depression, anxiety and depression using the GAD-7 and PHQ-9. Is it a direct correlation? I don't know the answer to that, but we do screen for that.
So I can say I will speak to this a little further along in my section, but there is definitely an independent correlation between depression and a COPD diagnosis, but I can't answer the question of whether dyspnea in and of itself, regardless of diagnosis, is correlated with depression.
Thank you, Amanda. So with this patient population too, unlike the oncology population, there's really a difficult time to know what the transition point is. When do you transition a patient to a palliative approach? Just the disease trajectory is so different from everybody, and it can be quite slow. For the trajectory of illness, long periods of slow decline with exacerbations may or may not be fatal. They're unpredictable, therefore prognostication is almost impossible. That transition point is difficult to identify. Patients' perception of a palliative approach may actually not align with management. We talked about palliative care is largely associated with oncology, and specialists for palliative care services for this patient population is not as well accessed as with, say, the oncology population. There are some tools out there to assess disease severity and to monitor. Certainly spirometry can be monitored over time. There's something called the Bode Index, which is perhaps the best prognostication tool for this patient population, which measures BMI, airflow obstruction, so the FEV1 via spirometry, the dyspnea through the MMRC scale, and then the 6-minute walk test. This is an interesting cross-sectional exploratory Canadian survey through the Lung Association with an organization called RESPTREC. So RESPTREC surveyed their certified respiratory educators, who could be nurses, respiratory therapists, pharmacists, to learn kind of what their knowledge around palliative care is. So when they did the survey, they asked the respiratory healthcare professionals, with patients with advanced respiratory illness receive optimal end-of-life care. And do these health professionals disagree? Are they neutral, or do they agree? And again, it was asking a very specific group of healthcare professionals. They're all respiratory educators.
Okay, it looks like we have almost everyone answering now, so I'll share it. So we have 32 people, or 62% of people, saying they disagree. We have 14 people, or 27%, saying it's neutral, and 6 people, or 12%, saying they agree.
Great. Yeah, it's actually pretty consistent with the actual results. So these respiratory healthcare professionals, patients with advanced respiratory illness receive optimal end-of-life care, and interestingly, 75% disagree that they receive optimal end-of-life care. 61% disagree, 40% agree. So I'll just go to the next question. Patients have a negative perception of palliative care. And I think this kind of goes across all diseases. And I'm sure, well, majority of people on this call, maybe not in your kind of sphere, but in our sphere in the respiratory world, they work closely with the patient with Health Quality Ontario and on multiple committees. And as soon as you mention the words palliative care to her, and she's actually on the palliative care chronic disease committee with me, and she didn't want to hear anything to do with palliative care. So it's, you know, is there a better way to approach this patient population as far as, you know, managing their symptoms better for symptom management?
Interesting. Yeah, the results came in really quick. People were quite sure about this one, and we have 46 people or 90% of people saying they agree.
Yeah, and then that would be consistent with the respiratory healthcare professionals as well. Agree 95%, so very similar results. 4.9% disagree. And I just pulled this to, there's the respiratory healthcare professionals that are out there. They know there's a knowledge gap for themselves. They know their patients need this service. So when asked, palliative care and management of serious symptoms should be an integral role of the respiratory healthcare professional, 93.5% agree. And then when asked, are they interested in palliative care training? 89% agree. So you can see that, the need, the want of the healthcare professionals really wanting to provide the best end of life symptom management care for this patient population. Did I miss any other questions in the chat? Because I'm going to turn it over to Amanda now.
So just while we switch presenters, there's a few questions in the chat, Wendy. Nancy was wondering if you could, I'm not sure, Nancy, if I completely understood your question, so feel free to add some clarification in the chat, but please explain titration of anxiolytics.
So I'm going to defer, Amanda will get kind of into those answers, so I'll defer that question to Amanda.
And then there was a question earlier on, and I'll come back to your question, sorry, Nancy. There was also a question earlier on, I think it was Allison that was asking it. What are wait times like for pulmonary rehab, and can referrals be made from the community?
That's a good question. Because of COVID, we've had to, so we have inpatient pulmonary rehab at the rehab center at the Ottawa Hospital. We have inpatient and we have outpatient. Inpatient is 6 beds. And that's for really, really compromised, significantly impaired individuals who really need a interdisciplinary supportive environment. For outpatient, there's a longer wait list. And again, it's because of COVID redeployment. I'm going to say 6 months, but I think it's fairly quick for inpatient. Can they be referred from the community? Yes. They do need a diagnosis of COPD with pulmonary function tests. If they have, a lot of people too will have emphysema on CT scans. A respirologist, if they have significant symptoms and history, they can do pulmonary function tests at the rehab center as well. Is there another?
And then there's just been a bit of discussion around in the chat about how people are often not ready to be palliative, and it might scare them, and that we could maybe change the name of the service to symptom care from palliative. Perhaps that's a less negative connotation from patients.
Yeah, definitely. I agree. And in working with patients and asking about their feedback, it's a challenge at the rehab center. They're there for pulmonary rehab, for exercise, and then you're going to talk to me about advanced care planning or palliative care. So it's a tough discussion. We need to really focus on the symptom. Well, we need to talk about advanced care planning as well, but also around the symptom management part of palliative care. I totally agree. So I will stop sharing.
If anyone has any questions while we're transitioning between screens, please go ahead and put them in the chat.
So Amanda will really get, as far as the palliative care medications, what to prescribe, how to titrate, and really apply that to a case study so that it makes sense. How much does COPD affect lifespan again? Oops.
Did you want to go ahead, Wendy?
Sorry, how much does COPD affect lifespan again? Again, there's so many factors that are involved there. We talked about BMI, how much they're exercising, if they're smoking, if they have any underlying health other concerns. So again, it's to take all those things in consideration. So that's kind of a difficult one to answer.
Mm-hmm. Thank you so much, Wendy. I learn from you every time you talk. Even though we've gone through this presentation together, I still took away some pearls. I love your very practical approach to how you talk about COPD. I'm sure people may think of questions as I'm talking, so feel free to put those in the chat. So this next section, we're going to talk a little bit more. We're going to work through a case study, and then we're going to talk about symptom management and a palliative care approach to address some of the common symptoms that patients have with COPD. But we're also going to focus on how can we work with some of the tools that they may already have and be working with it as part of their chronic disease management. How can we adapt and flex these tools to work in a palliative care context? So we'll talk about that a little bit as well. So I will read out the case study. Mrs. P is a 72-year-old woman with end-stage COPD with an FEV1 of 23% of predicted. She lives in her townhome with her daughter and her grandchildren and spends most of her time at home, but she can get outside for short outings, which she finds very tiring. She has just been ordered home oxygen at 2 liters a minute via nasal prongs. She removes her oxygen to smoke a few times each day. She reports she's short of breath most of the time. It's mild at rest and severe with certain activities. She's lost 8 pounds in the last 3 months. She coughs quite a bit in the mornings and it takes her an hour to clear her lungs. Then she doesn't cough much for the rest of the day. So based on this case, what more do you want to know about Mrs. P, or what further assessments might you make for this patient? So Sarah saying, is she using her inhalers correctly? Jose is saying, what are the triggers in the morning? Erin is saying, what are her meds? Arterial blood gases, dietitian. Julie wants her BMI. Aparna wants to explore her understanding of her disease. What is quality of life for her? And does smoking mean a lot to you? Ellie would like a PFT, pulmonary function test. Pam wants to know the fluid balance. Jose saying appetite. So she's losing this weight. How's her appetite? Stephanie, medications, especially puffers, but other things like steroids or narcotics. Lori wants a food intake schedule. These are great questions. Dawn wants to discuss a smoking cessation program with her. Debbie is asking, what meds is she using? Are they effective? What are her goals of care? Allison wants goals of care, addiction history, addiction screening, and how is her memory? Her SATs when she's short of breath and when she needs to sit down and rest. Does the oxygen help? Maybe some counseling, how she's doing on the stairs. Is the oxygen PRN or 24/7? Good. These are all fantastic thoughts. Pam saying, how effective is her medication use style? Great. So before we go on to talk about sort of further assessment of her and a COPD management plan, oops, I'm going backwards. Sorry, guys. I just want to share this dyspnea model that I came across. It was developed in 2009 by a working group. So dyspnea is sort of the perception of dyspnea comes when there is essentially a supply and a demand mismatch, where the body perceives that there is or the brain perceives that there is a need for a higher rate of respiration or more flow of oxygen, and the body cannot accommodate that for one reason or another. So when we look at the factors that influence perception of breathlessness and the sensation of dyspnea in a COPD patient, I'm not sure if you guys can see my cursor when I hover, but at the bottom is sort of the pathology. So it starts with an irritant, which irritates the bronchia, which causes structural changes, airflow limitations, buildup of mucus, ineffective airway clearance. This can be exacerbated by things like coexisting cardiovascular disease or loss of strength and loss of function as people get cachectic at the end stages of COPD. As they start to lose weight without trying, they lose muscle tone, they're more easier fatigued. And so they categorize that as lower limb activity that contribute to the perception of dyspnea. When we look at upper limb activity that contributes, over time, someone with COPD gets their sort of body makeup restructures. They get hyperinflation of their lung. They can't effectively exhale and blow off their CO2. Their oxygen levels are low. Their CO2 levels are often high. Their inspiratory pressures change, and there's a change in the ability of the respiratory muscles to compensate for that. So then you get issues with upper limb causes and postural triggers of dyspnea. So to go back to anatomy and physiology, there's afferent feedback and efferent responses, and they don't match. So there's a request for more, and we can't meet that request. So then that can even be exacerbated when there's a change in the normal rhythm of breathing. So the normal rhythm or pattern that the patient breathes when they eat or when they talk is often interrupted. And in the end stages of that, interrupting that normal rhythmic pattern is enough to trigger a dyspnea response. So then dyspnea being a subjective symptom, it also is impacted by things like our previous experience with dyspnea, as well as our anticipation of dyspnea. So previous experience, our perception of what's going to happen when I become dyspneic can also exacerbate the problem or worsen the sensation of dyspnea. So all of these factors combine to have the brain perceive a dyspnea sensation, which impacts quality of life and your exercise tolerance. So I really liked this model, and we'll come back to it a little bit when we talk about how different treatments can work to reduce that sensation or that perceived breathlessness of dyspnea. So how are we going to assess Mrs. P? So we tend to, oh, sorry, my chat box went back to the beginning. We tend to use the tools that we know. So in traditional palliative care, one of the common tools that I use is the ESAS, the Edmonton Symptom Assessment Scale, developed and refined and used at Cancer Care Ontario. It's not wrong to use an ESAS scale for a patient with COPD because there's a lot of symptoms on there that a COPD patient would have, such as fatigue, excuse me, sorry, I'm going to have a cough here. Hang on, I got to mute myself. Sorry guys, I get over a cold and sometimes I get a cough and I can't stop. I'm living the life of a COPDer today. So there's common symptoms that patients will have with cancer, like fatigue, depression, excuse me, shortness of breath, anxiety. They are assessed as part of an ESAS, excuse me, that are still relevant to a patient with COPD. So I don't think it's wrong to start with an ESAS. It can tease out some symptoms of concern. Where I think we lack at times in the palliative care world is stopping with, in particular with shortness of breath, in stopping with ESAS and not taking it a little bit further. Excuse me, sorry. So if we identify that there's shortness of breath, I think it behooves us to assess the dyspnea a lot more closely. And I personally like the CAT, the COPD assessment tool. It's another tool that you can monitor patients on over time and score them on over time and watch for a change. So when you do an intervention, maybe a few weeks later, you administer the CAT score again, and you see whether you've had improvement in their score level. So it looks at things like cough, phlegm, chest tightness, walking up a hill, energy, etc. So then you score them based on their rankings and you put in a total score, and then you can monitor their scores over time. I also specifically ask patients, so I ask them, yes, do you have dyspnea? Do you have dyspnea at rest? Do you have dyspnea with exertion? How long does it take for your dyspnea to resolve? But I also ask about specific dyspnea-inducing activities. So are you dyspneic with walking? Are you dyspneic when you're moving from sit to stand? How are you doing on the stairs? Are you sleeping in your bed versus in a chair? Excuse me, and how's your dyspnea? Are you dyspneic after you smoke? Does eating and talking make you feel dyspneic, as well as defecating. Often patients have to bear down to achieve a bowel movement, and sometimes that involves holding their breath, or it breaks that rhythm of breathing that we talked about earlier. And so defecating is often a very dyspnea-inducing activity for someone with COPD. I'm just going to put in a cough drop. Give me a moment here. Sorry about that. So looking at Mrs. P, an example of how her CAT score could look would be something like this. So she's rated phlegm as a moderate concern. A severe concern is getting up and down the stairs. She's quite limited in her activities at home. She's not too bad with her confidence leaving the home. She's sleeping, not great, and her energy is low. So her CAT score is 25. So now we have something objective we can measure over time to see whether our interventions are working. So on further inquiry, we learned she's always short of breath, more severe with certain activities. Showering and bathing make her dyspnea worse, as does walking down the stairs. She wakes 3 to 4 times a night to pee and falls back in her recliner. She's coughing in the morning and it makes her quite out of breath. She's struggling to eat, finds it tiring. Her appetite is reduced. She's anxious about what to expect and wants to make sure her affairs are in order for her kids. She's having some dry mouth and nose, loss of energy, and ranks her general well-being as low. Her CAT score was 25, which was worse from your previous visit, because you're a rock star and you've been doing CAT scores on your patient. So how will you manage her symptoms at this time? Before we talk about that, somebody's recommending I have a shot of whiskey. Thanks. I probably shouldn't when I'm trying to teach, though. But I like the way your mind goes, Huda. Before we talk about how we manage this patient in the chat, I'm going to skip to the poll question. Would you consider opioids for this patient at this time?
All right, it should be running here. If you want to take a little break, Amanda, or grab something, please feel free to. We can run this poll for a little bit here. It's all good. And if you're having trouble seeing the poll question, it just certain devices have that. Just write your answer in the chat so we still get your answer. Perfect.
So Amanda, we have one yes from a partner who can't access the question. And then there's lots of recommendations as far as garlic, honey, lemon mix. And Dario says no to the opioids.
This is the best possible group I could have a coffee fit in front of because they're going to have such excellent tips for me. So it's perfect.
All right. I'll share the results here, but it looks like we have 29 people or 62% saying yes, and we have 18 people or 38% of people saying no. So a little more split than other questions we've gotten so far today.
Yeah, and that's an interesting response because one of the questions I often get as a consultant kind of advising people in the community is, should we do opioids? Is it too early? Is it too late? So definitely we'll come back and talk a bit more about opioids. As a general rule of thumb for me, if a patient always has some breathlessness, even at rest, then they should always have some opioid in their system, because we'll see later how opioids are really first-line treatment of dyspnea beyond managing the underlying cause. For patients who have intermittent breathlessness, there's maybe less evidence for opioids. So maybe you could take a moment, I'll just go back to our case and tell me, what would you advocate for, or what would you offer this woman now to help manage her symptoms?
So Jose says sleep on the first level, if not already. Are there other kind of non-pharmacological recommendations you would recommend for Mrs. P? Nutritional services, that's a good idea. Smoking cessation program, puffers, head of the bed elevated, absolutely. Air in, let air in and practice breathing. Fan on the face often helps with shortness of breath. I would be looking at narcotics, but maybe also something for anxiety. Humidifier, helpful or not, not sure. Family meeting to review goals of care, that's a great idea. Positioning, Foley catheter bag, moist air. Fan for circulation, referral to home care for PSW services, nursing for symptom management, head of bed elevated, fan on face. There's a question, somebody had mentioned about the titration of anxiolytics, Amanda. Is here a good spot to discuss it or further along?
I think we can definitely chat about that when we talk about anxiety management, for sure. There's all kinds of good suggestions in here. Involve the family doctor, open the door to the bathroom when showering to lower the humidity, turn on the fan, biotin for the dryness. That's a saliva substitute spray. Lasix, narcotic, oxygen. So Lasix, it would depend if there's underlying congestive heart failure that's causing fluid buildup in the lungs, like that's contributing to pressure. If she doesn't have heart failure, there's really not a role for a diuretic for managing COPD related dyspnea. And correct me if I'm wrong, Wendy, please.
Yeah, no, not unless there's underlying heart failure.
So people are suggesting restrict her fluids in the evening, put a commode near the bed, PSW assistance again, protect her from falls, and if congested, scopolamine. So again, scopolamine, I mean, can help with congestion, but really upper airway congestion. We tend to conserve it toward end of life. The problem with adding it in too soon in a patient with a longer prognosis is that it's quite sedating, and it's actually going to dry up those secretions. And in a patient with COPD, we may not want to dry those secretions up. We want to get them out so that they're not building up in the lungs and causing bacterial growth and causing an exacerbation. Check for OSA, obstructive sleep apnea. Check for alpha-1 antitrypsin deficiency. I assume that's what that means. Good. The minute I start to talk, I feel that tickle in my throat. It's a conspiracy. So in terms of a dyspnea management plan, we're going to talk about opioids as being the mainstay for palliative management of dyspnea. Certainly anxiety management strategies we'll also speak about, both pharmacological and non-pharmacological. Always, we want to optimize the chronic disease management tools in this population. So we really want to make sure that they're using all those tools and resources that they got a year ago when they went through pulmonary rehab with Wendy. And then consider, is this acute exacerbation of the COPD, knowing that as we get closer to the end of life, those exacerbations often come closer and closer together. Having those goals of care discussion of whether or not we're going to treat and how aggressively we're going to treat these acute exacerbations. Oxygen. If they're hypoxic while they're dyspneic, there can be a role for oxygen. In terms of non-pharmacological interventions, so I often coach patients on mindfulness-based breathing exercises for COPD, and we'll go through one later tonight. Reinforcing the importance of doing their pursed lip breathing, so really as they're exhaling. Balancing activity and rest and energy conservation techniques, which I know was common in the chat for ideas. Positioning, so we really want them in that tripod position when they get dyspneic. That helps open up and expand the ability of the lungs to expand versus being crunched up or slumped over in bed. Optimizing equipment and supports involving home care. A fresh air or a fan. So a fan, we have little J receptors underneath our nose, and a fan blowing across them will trigger those J receptors and actually reduce the sensation of breathlessness. So there is good evidence and pathophysiology around using a fan. Doing lung clearance exercises, which we'll talk about later. And then transitioning from a COPD action plan to a palliative care dyspnea action plan.
Amanda, I'm just going to jump in here. There's a comment on smaller meals, eating frequently 6 times a day.
Yes, great idea.
Supplements, boost supplements. We know, especially with the emphysema patient population, their lungs are hyperinflated. The diaphragm's pushing down the stomach. So yeah, smaller frequent meals would be much more desirable. Pacing and energy conservation. Any tips for how to talk patients, residents about palliative care for COPD? What to say if they react with frustration to this?
Yeah, so to go back first with the nutrition piece, I often coach patients in the end stage of COPD. You will see people lose weight without trying, and they often develop cachexia syndrome. The reason I explain to them is the amount of energy that your muscles are using to expand those lungs is so much energy that you cannot possibly consume enough calories to compensate for that. So then you end up with people losing weight without trying, despite the fact that they're eating. Supplementing with boost involving dietary, using a high protein, high calorie diet are all great techniques, but it is often something that we see at the end stage of COPD. To go back to your question about how do you talk about this with patients, it's a bit of a loaded question. If we changed the name palliative care team to symptom management team, over time, would then people never ever want to see the symptom management team? I think it's part of human nature to want to live and to have a zest for life, and to have to face these difficult conversations that we often have in palliative care can be a challenge. I think it's so they've done a lot of research around how do you have these conversations sensitively, and the evidence really shows that goals of care discussions should be had with between patients and people who have had a longitudinal relationship with them. So I think initially those kind of feeler conversations, it's really best if it comes from their specialist, if it comes from their family doctor. Then, you could involve a palliative care team to maybe delve into their goals of care more in depth. But I think feeling them out on how aggressively they want things treated and is certainly appropriate. I often, when I introduce myself for patients with COPD, I often frame it as, I work with a team with a specialty in pain and symptom management, and when the time comes, end of life care. So I kind of do divide it out myself when I'm explaining it to patients, but it's a challenge. And I think part of it is that, going back to that slide Wendy showed, where patients are perceiving that they're doing this when they're actually doing that. So the patients perceive they're stable, but they're actually declining over time. And so I think it's really important to pull out those kind of lung functions and have a discussion about what's going on with your lung functioning. And we are seeing these downward trends. I think it is time that we address your breathlessness and that we have some of these goals of care discussions. Wendy, do you have any other suggestions for how you frame it to people when you're kind of offering palliative care?
Well, for the symptom management component, again, it's just, how to give you the best quality of life. So how do we manage your breathlessness? The kind of traditional COPD medications aren't working anymore, but there are a lot of other great medications out there to help manage your anxiety that's contributing to your shortness of breath. And then we talk about, a lot of people are afraid of opioids. So we talk about very low dose of opioid and the role the opioids have in helping manage that sensation of being breathless. So it's more around managing symptoms. as opposed to kind of end of life care. And they all want to have a better quality of life. And when you pull into, you know, what's your goal? I'd like to see my granddaughter graduate kindergarten. Okay, so what does that look like for you? So you kind of like attach it to something that's important to them as well.
So this next slide goes back to the dyspnea model we talked about at the beginning, and it shows where some of our common treatments that we will come up with in our treatment plan for Mrs. P act in this dyspnea perception to intervene. So smoking cessation certainly has a role as reducing irritants, as well as improving your PCO2 levels. So it can address the dyspnea sensation. Adding some supplemental oxygen can top up low PO2 levels. Of course, we have to be careful. Patients who have had COPD for a number of years, actually, many of them require higher CO2 levels in order to drive their breathing. So if we overshoot with oxygen, we can actually reduce the respiratory drive. So oxygen is really, we typically aim for SATs anywhere between 88 and 92%. We're not necessarily going to aim for a SAT of 100%. When we really have to monitor level of alertness, if we add in some oxygen and they're not able to breathe off their CO2 because we've knocked down their respiratory drive, they can actually become drowsy and groggy from the oxygen. So we need to turn it down and get those CO2 levels back up so they will breathe. Opioids work both on the perception of dyspnea as well as the physiology. So opioids will relax your smooth muscles of breathing and allow the patient to take a fuller, deeper breath. They also reduce the respiratory rate. So they will, if somebody's huffing and puffing and feeling incredibly dyspneic, they'll slow that down a little bit and let them take a fuller, deeper breath. They also modulate your dyspnea perception. So they reduce the sensation of breathlessness in the brain. We can think of things like antidepressants and anti-anxiety medications as something that we add in, particularly if there's anxiety in anticipation of dyspnea, or if dyspnea triggers anxiety. I often explain to patients that you get in this vicious cycle and you're dyspneic, and that makes you anxious, which makes you more breathless, which makes you more anxious, and you're in this vicious spiral. The opioids work more on the physiologic cause and slow down your breathing. The anti-anxiety medications help break that cycle by reducing that nervous feeling that's actually driving some of your high respiratory rate and driving some of your dyspnea. And then our non-pharmacological interventions can address the posture causes, the talking, eating causes, the emotion causes, so they can work on a number of different things. So really, when we're looking to come up with a dyspnea management plan for our palliative care patients, it's multifaceted, and we're going to address a number of things at once, simultaneously. So opioids and dyspnea, they are our mainstay for palliative care management of dyspnea. I always say it's one of the most important things that we can do as a palliative care provider when we're introducing an opioid is get that patient's buy-in. Often a patient has a perception that because they are on an opioid, it means it's the end of their life, or they're worried about risk of addiction. Healthcare providers can often be nervous about using opioids in the COPD population because they're concerned about respiratory depression. So how do I address that? I talk about how we use opioids in palliative care. So opioids actually have strong evidence that they are effective at 1/2 to 1/3 of the dose that we use for pain. So dyspnea actually responds beautifully to lower doses of opioids when compared to pain. So we always start low and titrate slow. So if I'm working with something like morphine, I might even start my morphine at 1 milligram and then titrate from there. So it sounds like a tiny little dose, but I have had patients who respond well to such a low dose of an opioid. So I always talk to them that, we're starting you on a very low dose. We're using 1/2 to 1/3 of the strength of an opioid that we would typically use for someone with pain. I also talk about how I have had personally many patients be on opioids for months and months, if not a few years, when they're in their end stage of COPD, because we know these people can live at a very physically dependent state for a long time. So they can be bedbound, chair-bound, and actually live for quite some time. In terms of when do you start an opioid, the evidence suggests that we should think about adding in an opioid in this population when there's dyspnea present with rest or with minor activity. There's really limited evidence of the benefit for dyspnea when dyspnea is only exertional. So if they're not dyspneic at rest, only exerting themselves is causing dyspnea. Very often there's not a great role for an opioid. The other time we think about adding in an opioid is when the patient is refractory to the standard COPD management tools. So they're dyspneic, they take their puffers, they do their mindful breathing, they sit themselves in the tripod position, and it's really taking a long time to settle that dyspnea. Then we want to think about adding in an opioid. And of course, in this population, it's so important to address the constipating effects of opioids, because the last thing we want someone with dyspnea to do is to sit on a toilet and try to strain to have a bowel movement. So I see there's a question, do I have a preferred anti-anxiety medication? So I will talk a bit about that. So first of all, I think it's really important to remember that there's a strong association between both chronic disease and depression, and there's a specifically strong association between COPD and depression. So we really need to screen for and manage and treat any underlying depressive symptoms. Then in terms of the anxiety piece, my approach is if the patient has anxiety that's very obviously triggered by their dyspnea. So I'm not talking about people who have a baseline anxiety, and I'm not talking about people who maybe have been struggling with anxiety for years and years and years. But for patients where it's very clear that their anxiety is exacerbated by their dyspnea, or that their anxiety is triggered in anticipation of their dyspnea, I typically use midazolam. So midazolam is a benzodiazepine. The beauty of midazolam is it's quick to onset and doesn't last very long. In most people, it lasts less than an hour. There is some evidence that suggests it can last up to 3 in some frail elderly people. So I typically use midazolam. You can really dose it very tiny, 0.1 to 1 milligram, subcutaneously or buccally. So you can use the subcutaneous vials of midazolam, draw them into a syringe, and the patient can squirt it into their cheek or even under the tongue, and it kicks in pretty quick. So I typically instruct my patients to take their midazolam either prior to a dyspnea-inducing activity, or if they're really can't settle themselves, then it's part of my action plan for when their dyspnea is severe. We have to be cautious because midazolam is so short lasting. If somebody really has a background of anxiety, you have to think about treating the background anxiety with something that's longer lasting. Because the problem is if there's always some background anxiety and we give this midazolam, as soon as it wears off, they have a rebound in their anxiety and they're that much more anxious. So it's really important for those patients to consider something longer lasting. And I see there's a suggestion for lorazepam. I don't use a lot of lorazepam, but it wouldn't be wrong as long as they tolerate it. I often will use clonazepam, like Stephanie's suggesting. So sometimes you can use clonazepam. Sometimes I've used it just at bedtime, or sometimes you can use it every 8 hours in a patient who's very, very anxious. Of course, you have to remember all of these medications carry with them a higher risk of falling. So we're going to start low, we're going to titrate slow, and we're going to monitor for side effects. In terms of non-pharmacological anxiety management techniques, we talk about Wendy, you explained this so beautifully. So I might ask you, if you don't mind unmuting, to explain how you talk about normalizing the breathlessness. I think you hinted at it earlier, but if you don't mind talking about how you explain that to patients.
I think a lot of it, as you say, the anxiety and the shortness of breath, they get themselves into this vicious circle. So, you've taught them all the kind of the strategies, they're taking their medication, maximally. And I guess just the deep breathing exercises. I know we had discussed this as we were preparing for the presentation as far as normalizing. Now I can't think of the train of thought to where I was going with it.
No, but I think you were just saying, you need to normalize breathlessness, that, it is normal that you will feel breathless after certain activities, and reinforcing to pause, reposition yourself, and take a break.
And that's where the action plan comes in, so that they are able to identify on the green days what they can do, the medication they should take. And then, take the medication before things like showering and bathing, grooming, dressing. So just, to have a very clear plan in place for them, a supportive plan. And yeah, normalizing as far as when they are breathless, I think I talked about it, it's not an occasion to crank up your oxygen. That is the occasion to, it's okay to be breathless. Stop what you're doing, practice your breathing techniques, in through the nose, out through the mouth. And I always tell them, you're flickering the candle when you're breathing out through the mouth. You're not, blowing out through the mouth. So just really reinforcing those breathing strategies with them. And give them some control too from Pam. That's a great idea.
I agree. So in terms of secretions, in this population, the secretions can be tenacious, meaning thick and difficult to get out. They can be copious, so there can be lots of them, or sometimes they're a combination of both. So there's lots of them and they're thick and they're hard to get out. So a lot of times these patients are on oxygen, and oxygen can make this situation worse because it's so very drying. One of the first steps you can take is to humidify versus not to humidify the oxygen. And I often have this discussion with the respiratory therapist who's following the patient. If their secretions are so thick and they can't get them out, they're going to build up in the lungs and they're going to grow bacteria and they're going to cause an acute exacerbation and an infection. So it's really important to get them out. But if we add humidity into the oxygen, we're creating a moist environment, which of course pathogens love. So we could be increasing the risk of an infection. So it's a benefit versus risk. If those secretions are horrible and terrible for them to get out, it may be worth a trial of humidifying the oxygen. But there are, of course, rules and restrictions around how high the oxygen flow can be before we get an adequate uptake of the oxygen. So I think it's best between 3 and 6 liters off the top of my head, but a respiratory therapist would know for sure. I don't typically use mucolytics, although I have seen them in my ICU days. I haven't seen them in the community, but there are mucolytic agents like acetylcysteine. You can use 3 to 5 milliliters. Often you can combine some saline so that it's easier to nebulize, but it's nebulized up to 4 times daily. I don't think it's covered in the community, but it is covered in the hospital. Side effects can include nausea, vomiting, tachycardia. So it's a medication that can be very difficult to tolerate. But that being said, you may find a patient who's been on it and tolerated it well and is willing to continue. And Stephanie's saying pre-COVID, we did nebulized saline. Absolutely. So I have had great success with just simple normal saline. They can nebulize 5 to 10 milliliters 4 times a day as required. And that often just sitting there breathing in that moist air is enough to hydrate both the nostrils and the lungs. And Aparna is suggesting guaifenesin tabs. I haven't used those. I got to admit, I don't have much familiarity with them. And then, as always, we want patients to monitor the quantity and the color of their secretions in case this is an acute exacerbation. In terms of lung clearance, you guys have probably seen these in patients' homes, but there's different devices that patients can use that they basically oscillate the lungs. So the patient breathes into them and they cause oscillation in the lungs, which helps loosen tenacious secretions and helps them expectorate it. In the very frail end of life palliative context, sometimes these are difficult for them to do. It is quite a workout to do this chest physio with these valves, but certainly if they can tolerate it, it's worth encouraging them to continue it. And Wendy, do you mind speaking to the question about color of secretion and why this matters?
Yeah, when you're monitoring patients for an acute flare-up, you're looking at increased shortness of breath, increased cough, and then their secretions as well. We want them to monitor the quantity and the color. If a patient, if they're normally a clear or pearly white secretion and they're turning yellow and then to green, you know that they need an antibiotic in addition to likely prednisone if they have more shortness of breath and coughing. So it's really important for them to monitor those secretions.
So a part of the Aerobica is, I think it's fairly expensive. It's probably $60 or so. I think the little one, I don't know what it's called, but the little one with the white one is a little bit cheaper. But sometimes with a prescription, patients can get reimbursed from their private drug plan. And they can also order these devices over Amazon, or they can get them through like Shoppers Home Health.
The other two, just to jump in, one's
Yeah,
called a flutter and one's called a, shoot. I just had it. Sorry, aerobica, flutter, and I'll come back to me.
Yeah, I mean, they're not overly expensive, but for some of our patients where finances are concerned, it could be a bit cost prohibitive. Aparna, were these the specific equipment you were wondering about, or were you also wondering about home oxygen and other things like that? Sarah, to go back to your question about chest physio from physiotherapy or respiratory therapy, I don't know if there's, maybe Wendy can answer that question. Is it superior to aerobica? I think they've found that it's equivalent, but I'm not 100% sure.
I don't know if it's superior. I know we encourage the aerobica, just it's a lot easier. The patient can do it themselves. And a lot of our patients are frail, you know, as far as, and cachectic. So as far as doing chest physio on them may not be ideal when there is a lot of excellent evidence to support a cappella, flutter, and aerobica. The other one's a cappella, these devices. And it's important too, when using these devices, to encourage the patients to drink a lot of fluids, because you really want to loosen those secretions so the patients are able to cough the secretions out.
Great. So xerostomia, the fancy word for dry mouth. A lot of times patients have dry mouth because of oxygen, but they might also have dry mouth because of some of the medications that we have them on. Certainly opioids are a culprit for causing dry mouth. So when I think about dry mouth management, I think of two options. We can stimulate saliva production, or we can substitute for saliva. Things that stimulate your saliva are things like chewing gum, sucking on hard candies, and eating and drinking small amounts. Things that substitute your saliva are sprays, gels that you can get over the counter or behind the counter. Moisture spray is one that's commonly encountered in the hospital setting. Taking little sips of fluid. Our salivary output naturally decreases at night. So adding a humidifier, a small humidifier at the bedside at nighttime can help with some of the morning dryness that people have. And then there's another product called Xylee Melts that you can get that's just a little tablet. You stick it onto your tooth and it creates a lot of saliva in the mouth. I personally don't have a lot of experience using Cialagogues. There is Cialor, a 25 milligram tablet that they can take 3 times a day prior to meals, but it's known to cause significant diarrhea. Off-label, you can use pilocarpine drops, TID to QID, but you really have to be careful in patients with any kind of cardiac comorbidities, as it can contribute to bradycardia, and it's also difficult to tolerate GI-wise. I did come across this homemade mouthwash recipe that you could instruct your patients to use. And it's a third alcohol-free mouthwash with a third normal saline and a third hydrogen peroxide, and plus or minus a little bit of glycerin, and they whip that up and then they kind of rinse their mouth with it. Cost of Xylee Melts, I think it's about $11 for about 10 or 20 of them. But you would have to ask at the pharmacy for sure, because everything has gone up with COVID, so it's probably more now. Dry nasal passages. I feel like I have, still to this day, I have yet to do a great job managing this symptom in patients with home oxygen. I remember a case I had once. It was a patient who had such dry nostrils. She was putting in Seqirus, but then the Seqirus was creating this kind of gunky, thick buildup inside of her nostrils. So then she was picking it out, and then she was having bleeds, and it became such a messy situation for her. For her, I actually consulted ENT, and they recommended debridement, but they also recommended this kind of stepwise approach, and that's what I have here. So first, you want to think about doing nasal irrigation twice a day with a neti pod or any of the other over-the-counter nasal irrigations that are available. Seqirus is a great agent that they can apply BID to TID. The big thing about Seqirus is you have to be careful that they don't just do the tip of their nose. They really need to get up higher in the nose, apply it to the walls of your nares, not just stick it in, and really rub it in so that it's absorbed to create a moist environment. You can get little nasal mist sprays or consider a prescription nasal steroid. Nasal steroids can work great for some of the inflammation that people can get over time with chronic dryness, but They can cause local issues. So over time, they thin the walls of the nose and they can cause nosebleeds. So if nosebleeds because of the dryness have been a problem, adding in a nasal steroid might not be ideal. Humidifying the oxygen, nebulized saline, like we already talked about. And then in extreme cases, we may need to involve ENT because it's just so dry in there, but they're oxygen dependent. One thing I didn't include on this slide, but involve the respiratory therapist, reach out to them. There are lots of different types of masks that patients could try. And so I have often encouraged my patients to take off their nasal prongs during the day and sleep with a mask on if they can tolerate it, because it just rests the nares from that direct oxygen flow going across them. Yeah, Ellie's saying it's a real issue she has with her patients on oxygen. I agree. It's challenging to manage for sure. Managing cough. So cough is one of the most commonly encountered symptoms in patients with COPD. Cough and dyspnea are number 1 and number 2. It's a fine balance. Patients with COPD need to cough to clear their secretions. So we really don't want to suppress that cough too much. But sometimes the cough trigger gets so overstimulated that they fall into these unbearable coughing spells like I had earlier, where they just can't break the coughing cycle. And so we do have to intervene for their quality of life purposes. As always, with anything COPD, we're going to treat any underlying cause. So if they have a postnasal drip, asthma, GERD, we're going to look at treating the underlying cough cause. In terms of smoking cessation, so there is actually evidence that the antitussive, so the anti-cough benefit, can kick in within 2 to 4 weeks. So if we're getting involved with these patients earlier and they have a longer prognosis, there may be some potential symptom benefit from quitting smoking. Our non-pharmacological things like humidity, positioning, elevating the head of the bed, deep breathing and coughing exercises for sure. Opioids really are the mainstay of treatment, again, for cough suppression. So elixirs like Hycodan can reduce your cough by up to 70%, and a long-acting opioid can reduce your cough by 70 to 90%. But again, we have to be careful. We don't want to suppress the cough too much and then have those secretions sitting there. In extreme cases, you could look at local anesthetics. So I've not used this in the COPD context for cough, but in the cancer context, I have used nebulized lidocaine. You have to be careful because it numbs the swallow reflex as well. So you really don't want someone eating or drinking after they use it. And there is some off-label evidence for Paxil for cough. Again, I've not used it in the COPD population, but I have used it successfully in patients with cancer-related cough. Health teaching. So number one is a big nursing place where nurses can make a huge impact for our patients is observe them taking their puffers. Are they using an aero chamber? Are they waiting a full minute between pushing the button on or pushing the valve on their puffer? Are they able to have enough inspiratory effort to get that puffer delivered where we want it to be? This is a case where there may be, if you see like they really don't have great inspiratory effort, you may want to think about having a nebulized medication where they can just passively breathe it in when they're in a real crisis and they can't make that effort. Mindfulness-based breathing. So I promised you guys a COPD-related breathing exercise. So the breathing exercise I teach to most patients is called box breathing. So if you picture a box in front of you, you can draw it on a piece of paper. You're tracing up the box to inhale for 4 seconds. Hold your breath for 4 seconds. Exhale for 4 seconds. Pause for 4 seconds before you breathe. And you do that a couple of times. The problem with trying box breathing with someone with COPD is they have a prolonged expiratory phase. So they need to exhale for longer than they inhale. So rather than teaching box breathing, we encourage them to plant their feet on their chair, become aware of where they are, calm their breathing, and then we're going to do more like rectangle breathing. So they're going to breathe in for 4 if they can, 2 to 4 seconds. They're going to hold for 2 to 4 seconds, breathe out for 8 seconds, and then hold for another 2 to 4 seconds. So it's a little bit different than box breathing, but you really want to teach them to focus on their breaths, do some counting, because that mindfulness and that counting and awareness is going to help calm them down when they're exacerbated. Again, the pursed lip breathing, balancing activity and rest is really important. Definitely If there's a particular dyspnea trigger, like I think about shower day is often a very dyspnea-inducing day for some of these patients. So if you know Wednesday is your shower day, Wednesday is not a good day to plan to have a family reunion, because you're going to be tired after your shower and you're going to need to take that time to rest and calm your breathing. So just discussing that importance of balancing. Positioning, as we talked about, tripod positioning, being upright. One thing I often use with patients is called A frame. So if they're in a hospital style bed with the head elevated, you use pillows behind them to make an A. So you 2 pillows on the side, 1 across the middle to make the letter A, and then you rest them back against those pillows. And that just helps expand their breathing that much more. And then always, do they have enough support? Is the family having enough support? So going back to Mrs. P, we started her on some morphine sustained release, 10 milligrams daily, with Senecot and PEG for her bowels. We started her on midazolam 0.5 milligrams buccally 3 times a day PRN prior to dyspnea-inducing activities. We involved home care nursing and PSW to assist with her bathing. We sent a referral to physio and occupational therapy so they can look at equipment, consider a hospital bed, maybe a bedside commode like what was suggested. Added some humidity to her oxygen setup, and then we did some teaching about nutrition, energy conservation, and the appropriate use of opioids. So this is another tool I came across by a palliative care group who adapted the COPD action plan to become a COPD palliative care action plan. I think this is so important for our patients because they're often transitioning from self-management to caregiver management. And sometimes caregivers haven't been very involved in knowing the steps. And also when a caregiver sees somebody breathing so fast and in so much distress in front of them, that's incredibly worrisome for the caregiver. So by developing these COPD palliative action plans, I think it makes it very clear for the caregivers the steps that they can take for their COPD patient. So a typical morning routine, if you're feeling great, you're in the green, you'll do your deep breathing and coughing, your mindfulness breathing, you'll take your puffers and your long-acting opioid. When you're more out of breath than usual, so you're in the yellow, you're going to use an extra PRN dose of your opioid. And then with predictable shortness of breath, with any sort of particular activity, you're going to time your puffers and your opioid and maybe your anxiety medication half hour prior to your dyspnea-inducing activity. For crisis shortness of breath, so it comes on quickly and takes you by surprise and you're in significant distress. Use your fan, do your pursed lip breathing, sit upright in that tripod position. Take 2 puffs of your rescue inhaler or do a nebulizer. Adjust your oxygen flow. Again, that's only if we're really looking at end stage and only if they've been instructed and recommended to do so by the respiratory therapist. Take your anti-anxiety medication and your as needed opioid. And then I always add, call your nurse or your community paramedic after however many minutes. Rather than calling 911, call the nurse or the community paramedic. Then always remember to monitor your sputum color and amount. Is this an acute exacerbation of COPD? I also recommend that patients with COPD who are close to the end of their lives have an action plan for COPD exacerbation and a standing prescription for antibiotics and prednisone. So it's really ideal, at least if the prescription is sitting at the pharmacy, so that we're not having delays trying to get in touch with a prescriber to order these medications. And Aparna, yes, it is absolutely possible to access this plan. We're going to be sharing our slides after this presentation. So please don't hesitate to copy this and bring it into your everyday work. I would love to see these out in the community. So here's our next poll question. So thinking about Mrs. P, you guys thought we were done with her, but we're not. Would you explore smoking cessation with her? Yes or no? This is how we know if people have been paying attention. We see if people are voting or not.
It's like we got most people so far. I'll just give it a couple more seconds here. All right, so it looks like 37 people or 77% said yes, and 11 people or 23% of people said no.
Yeah, it's interesting. You know, when I was preparing for this presentation, I did a lit review, and I think it shows that a lot of palliative care providers don't often explore or recommend smoking cessation with their patients. And my team, we meet once a week and have sort of a clinical rounds, we call it, where we discuss cases. And I asked this question a few months ago to my team of expert consultants. Do you guys talk about smoking cessation with your palliative care patients? Do you push them to quit smoking? And pretty much all of us said no. And the reasons why we'll talk about after. But when I was preparing for this presentation with what I learned, I actually think I'm going to change my approach. And I think I will be a little bit more open to talking about smoking cessation, or maybe encourage my patients and have a better way to encourage my patients to quit smoking. So why in palliative care do we not talk about smoking cessation? Often there's a perception that talking about this to someone who's close to the end of their life may cause some guilt or undue stress that's not necessary at this stage in their disease, as well as a perception that we're so close to the end of life. Are we really going to be able to impact them? And so the data actually do show that we can make an impact. So a reduction in heart rate and blood pressure can occur as early as 20 minutes once they've stopped smoking. Reduced CO2 levels can occur within hours. And then reduced cough and sensation of breathlessness can occur within 1 or 2 months of quitting smoking. So if you're working with a palliative care patient who has a longer trajectory, it could perhaps behoove us to put a bit more effort into working with them about smoking cessation. This is very similar to the Fletcher graph that Wendy showed earlier. So I'm not going to spend a lot of time on it, but it's from St. Michael's, and it's a quit smoking aid. And it just shows that even if you're very late stage when you quit smoking, you can significantly impact your walking and reduce your urgent care visits. So there is significant, like Wendy was saying earlier, there is still evidence and of benefit from quitting smoking, even very late in the illness trajectory.
Amanda, if I can just jump in before the poll question. Just Beverly says encourage it but not force it, as it itself can cause stress.
I agree.
Elliot offers hope.
And sometimes I have had patients tell me, this is the one thing that gives me pleasure, you know, I'm not willing to give it up. And I mean, there's whole research on what's the best approach to assessing readiness for change and interest in change. And so that could be a talk in and of its own self. But personally, I even fell into the habit of not even asking if they were interested in quitting. And I think this just sort of reinforces the importance of still asking, still offering, even if we are late in the disease trajectory. Sorry, Wendy, did you have something else you wanted to add?
No, I agree with everything points. I was just going to read just another comment as well. Somebody they would explore it, but not to be too pushy. And somebody else suggested motivational interviewing. That's
a great suggestion. Maybe Eileen will give us a talk on how to do motivational interviewing. I feel like I can use it. So this poll question, how often do you use nicotine replacement therapy for palliative care patients who have been smoking, but now, because of perhaps disease progression or where they are in their illness, they are no longer physically able to? Never, rarely, sometimes, often, or always.
You know, they've come up with so much great nicotine replacement, different devices, or, you know, between, you know, initially it was just the patch and the gum. Now they have the inhaler, they have the mist. So there's so many different kind of devices that patients can use. There are a lot of great options out there.
Mm-hmm. Especially sometimes, you know, by the way their disease progresses and their energy reduces, they kind of naturally start to reduce how much they're smoking just because of how unwell they're feeling. And so if they're really only smoking a cigarette here and there, you know, trying some of these alternatives might not be so daunting to them, you know, trying an inhaled one or inhaled nicotine or replacement. So we're kind of a mixed bag, right? About 37% said sometimes, 22% said rarely, 27% said often, and then 4% said never, and 3% said always. So we're kind of like that perfect bell curve of most of us fall in the middle of sometimes, and I'm not surprised. So in terms of nicotine replacement therapy, there is actually some withdrawal symptoms, particularly at end of life, that can present as restlessness or terminal agitation, irritability, and delirium. So there could be benefit to adding in a nicotine replacement therapy to reduce some of that those symptoms of delirium that patients might get at end of life. So if you have someone close to end of life who is experiencing delirium, always remember to think about, could nicotine withdrawal be a cause? There's tons, as Wendy was saying, there's tons of products out there for smoking cessation. Certainly at end of life, we're not looking at the oral tablets that are along the bottom here, but we may think about a patch. So if a patient is smoking less than 10 cigarettes a day, a 14 microgram patch would be recommended. And if they're smoking more, it's a 21 microgram patch with a tapering course, but we may not get there if they're at end of life. So in terms of resources moving forward, Wendy prepared this lovely resource slide for you guys on some good tools for your practice. And as we mentioned before, you'll all get copies of this presentation. So please feel free to explore these resources on your own time. So it's 8:20. So we have about 10-12 minutes for questions or discussion.
And just to acknowledge Beverly's comment, it takes a point that there is no longer the need to smoke as well in the chat.
So far, I'm not seeing questions, but I'm seeing some positive feedback. Thank you very much, guys. So I'm really hoping that after this presentation, you guys feel a little bit better equipped to manage dyspnea in the home, home context, or in the palliative context, I should say. You know, please feel free if you think of any questions, you're maybe not comfortable to put them in the chat, do feel free to email Carl and he can get in touch with us with your questions.
Yeah, absolutely. We'll give it another minute here or so, but so far it's all just compliments for you both. We have
you can tell we both have a nursing background, right? Because we're very practical people, right? What do I do on a day-to-day basis? You know, very practical.
Yeah, we have, I have to keep scrolling up because there's so many coming in, but Sarah says, this has been excellent. Thank you. Best talk I've been to in ages. Oh, that's great. And Melanie says, awesome presentation. Another excellent information and presentation. Lots of good points. That's great. That's great to hear. I hope you both have a chance to read through that.
Carl, you're even getting some kudos in there. Thanks to you too, Carl, says Pam.
Perfect. Well, I don't.
And seriously, thanks to you all for participating and giving us such good questions, because I think it's always easy. It's hard when we do these webinars because we can't see you guys. And so it's really helpful when there's a lot of participation in the chat to make us feel engaged, you know, and help fill out some of the gaps